Basal Implantology was invented in 1975 in France, in the University of Paris.
We installed around about 25,000 implants in more than 5,000 patients.
There is no difference between smokers and no-smokers in the success rate, even in the long-term success rate.
I'm Dr. Frank Spahn. I studied in Germany and in Belgium, in Aachen, University of Aachen and University of Brussels, and I have the medical and dental degree, and I'm maxillofacial surgeon. I started implantology in 1973. I have private clinics in Brussels and in Cannes in France. And I'm giving courses in universities and in other installations all over Europe about surgical implantology. In 37 years under my responsibility in the different clinics, we installed around about 25,000 implants in more than 5,000 patients. It has been patients who couldn't be treated by other means, and generally it were high-risk patients.
I'm Dr. Thomas Meyer. I'm working in the south of Germany. I have there a little dental clinic. I'm the clinical director of this clinic, of this staff there, and it's in Oberkochen, the little city in the south of Germany. I do dental implantology and basal implantology since 15 years. I'm doing a lot of these implants every year, some hundreds and nearly thousands, and it's the whole office and the whole clinic is specialized to clinical implantology and to periodontology.
Hello, my name is Stefan Haas. I'm a German dentist. I live in the near of Berlin, and I started with the implantation about before 12 years. I take screw implantation and BOI implantation, and the difference is how many space is in the bone. If we have only 4 or 5 millimeters like here to the sinus, then we have take the BOI implantation. If we have enough space like here, then we have to take the normal screw implantation or implants. You see? Next, please. No space. We are under the sinus is not open, and it's very strong and hard. And here we can take the Champions implants, and the best is that these implants are very fast, can get the prosthetic. Oh, it's the same, another case, you see some radix, you see here no more space, only 4 or 5 millimeters. Here is enough space, and this is the same to take this or that implant. Next. So here we have done screw, and BOI. The question is why I take the BOI implants. I take the BOI implants because I want to take for the patients, I want to make a non-removable prosthetic, and I don't like the synthetic bones and bone graft to take it like sinus lift for the patients.
The difference between crestal and basal implantology is that in the crestal implantology, the crista, this is the part of the bone where the teeth are anchored in, is used to insert an implant, and when this crista doesn't exist, we install the implants in the basal bone, the bone which always exists. I can show you this on a model. Now we have here in this region, we have a crestal bone, and up from here it should be named basal bone. So when we are working in the basal bone, we speak over basal implantology, and when we have to do with implants in this part, we speak about crestal implantology.
Basal implants are always immediate loaded because of the multicortical insertion of these implants. It's not inserted like conventional implants in the spongiosa of the bone. It's inserted in the cortical bone. So there's a very better stability, primary stability of these implants. And most important, you can insert the implants also in fresh extraction sites. You have not to wait the healing after extraction. You can put them immediately. And so it's good for, especially for complete cases, to do complete cases, maxillomandibular at once. Even in, or especially in cases of severe or even extreme bone atrophy of the jawbone. And there is no indication for any bone transplantation, for sinus lift or things like that, which are very, very aggressive surgery and very intense surgery. It isn't necessary. Basal implantology is a prosthodontic discipline with using the tool of surgery.
Other differences between the basal implantology and the crestal implantology are those of the interface of the implant. This is the part of the implant where the constraints go, the constraints from mastication will go in the bone. And this is an interface in crestal, which is in crestal implantology, which is vertical, and a basal implant is transferring the forces via a horizontal plate to the basal bone.
Basal implantology was invented in 1975 in France, in the University of Paris. It was introduced by, not only by dentists, by engineers, which looked for a system to treat these atrophic jaws, where there was no possibility to do it with conventional implants, with screw implants or with cylinder-formed implants or bullet types of implants. We have done in our clinic a study of the long-term success of basal implantology over 8 years. There's a success rate of 79.8% over these 8 years, and in France there was done a big multi-center study of about 20 years, and there was a success rate of around about 90%. So it's a little bit higher than with conventional implants.
High risk will say in implantology that with the operation which is necessary to implant the posts in the bone, there could be fractures because the bone structures are not heavy enough and not thick enough to be used for implants. And if we have not much bone, besides a structure in the bone which has to be conserved, we speak about basal implantology, because this basal plate is avoiding to the necessity to go in the depths of the bone. It can be installed very in the surface of the existing bone. Normally you have a crestal bone and you have a basal bone. All this here is basal bone, and this part is on the basal bone. This is the crestal part, which is normally also in this region, but in the same highness as here. So this part of bone is now resorbed and we have only the basal bone, and just beneath here is a nerve which is very, very important, and we may not bless this nerve, so we will use basal implantology because the transfer of mastication forces is distributed via this horizontal plate, and this avoids to need the depth of the bone for distribution of forces, of mastication forces, like in crestal implantology. The outcome after a long period, like 20 or 30 years, is in the two implantology in the two implantologies almost the same. It's around about 97% or 98% of success, and you have to consider that the cases which are done with basal implantology generally are only to be managed with basal implantology, and the crestal implantology can't help here because there is no crista, there is no processes of bone where the teeth have been fixed in. This process is away, and you can't really fix their crestal implant. You should do bigger operations, or heavier operations, like bone transplant, bone graft, to create new processes to insert there the implants, and afterwards you can charge these implants, you can load these implants with prosthodontics. In basal implantology we use the bone as it is in the anatomy of the patient. We don't change anything in this anatomy, and we just use the anatomy to install our implants, and he can normally immediately have his prosthodontics.
In our clinic before we do surgery, we do a periodontal treatment. We look for healing aggressive periodontitis or to treat chronic periodontitis, so that there are clean and stable clinical situations, not contaminated with lots of aggressive bacteria. A study we have made in our clinic is that there is no difference between smokers and no-smokers in the success rate, even in the long-term success rate. You must imagine most of the patients who need basal implantology are smokers or had a history of an aggressive periodontitis. That is also important. These are cases which are reported every case, not only selected cases and with exceptions, but every case which was in the clinic about this team, and there were no exclusions of smokers, of people with bad bone, or it was accepted everything. And we did also a comparison of the bone classifications, and we did even the worst cases with bone classification, the C and D, not only A and B, we did especially the bad cases, because they were needed. Good cases don't need implantology. The success rate we reported was only with cases which were extreme and at least severe. There were no easy cases about them, and it was cases of the complete maxilla, not only single implants, one or two implants, but complete cases with a lot of implants, and which were extracted before and which had a history of periodontitis and of smoking and of bad dental hygiene and all these bad things, or things who may be contraindications for normal implants, for crestal implants.
The success rates are almost the same, with the difference that you can't help patients with crestal implants when there is no bone. So using the bone in the individual anatomy of the patients just with basal implants is the big advantage of basal implantology. In the two solutions we can eventually load the implants immediately. Immediately means in a very short time after installing the implants, or really on the same day. This is not depending from the system of implants you use. This is depending from the technicians you work with, because they must be able to fabricate the prosthodontics, and there are today different methods to have this fabrication procedure in some hours, or as it was 20 years ago, it will last 5 days or 6 days, but all this is immediate loading of implants. We don't speak of immediate loading of the implants, but of a two-stage implant, then we mean that the loading will only be done after at least 40 days, when the reconstruction of the bone is done, and when there is solidity, stability of the implants in the bone. The mineralization of the bone in this moment is not yet done. It will only be done up from the 40th day, but the stresses of mastication will help the bone to intensify the mineralization, and the stability will be better with mastication. So all prosthodontics installed before the 12th day, we speak of immediate processes, and all loading after the 40 days, we speak of two-stage implants.
Basal implantology is a specialized subject. It's not promoted by the industry, because there is not the big industry and there are not the companies like in crestal implantology, and it's a specialized discipline. And there is not only one discipline, it is a discipline of prosthetic dentistry in combination with surgery. So the doctor needs to be very abundant, specialized, if you can say it like that, in more disciplines. And it's a discipline of dentistry. It's not a discipline of maxillofacial surgery. Most of crestal implants, or the so-called implant specialists, are surgeons, and they often cannot work the prosthetic dentistry. They refer to the normal dentist to do the prosthodontics, and that's, I think, a big mistake, because it's better if one dentist is responsible for the whole case. So he is doing every part which is necessary, and not only something here and another does the rest. So one responsible doctor and one responsible partner for the patient. That's a big advantage for the patient. according to the history of basal implantology, it's taught at the universities in France, especially in Nice and in Paris. And there is also at the University of Belgrade in Serbia. And since this year it's taught at the University in Rostock in Germany. And so it will be more and more widespread. There are very severe meanings which don't tolerate basal implantology at their universities. That will change, but it will need time. That's not from today to tomorrow. And it's not a theme to big industrial promotion of this subject. It's a serious and it's a good subject, and it must not be treated cheap and must not be treated fast, but it must be treated good and acceptable. That's more important.
Normally, in almost 99%, a basal implant is a one-stage immediate loading implant, and on the other side a crestal implant in 90% is a two-stage implant, and in 10% it may be used as a one-stage immediate loading implant. One other difference with crestal implantology is in basal implantology that many topics which are seen as a risk in crestal implantology are not considered as a risk in basal implantology. This is because of the special healing of the basal implants in bone, which is different from the healing in of crestal implants. So even if we have to do with a smoker, or if we have to do with a patient with non-continuity in his bone structures after, for instance, having lost other implants, crestal implants, we can manage an immediate loading procedure with the basal implantology. The patient naturally has to follow our recommendations. But as I told you, 99% of the basal implantology is considered to be charged and to be loaded immediately. Basal implantology is invented around about 1969 and was developed by Jean-Marc Jouyet, a French implantologist who worked with other systems which were common in this time and in this period. Which have disappeared in the meantime, but the basal implant stayed till today because of his special indications and because those cases can't be solutioned with crestal implantology. I have been assistant to Professor Jouyet, and we worked together, and afterwards with my group of implantologists in Germany we continued to develop the system in titanium, which has been used in the state of development up from 1989 till today. There are almost no changements because the system is improved, and we had a solution in our different forms of basal implantology almost for every indication for every patient who should have a problem.
You must be experienced in dentistry. That's important, that you have an overlook over the whole dentistry and you know, even prosthodontics and periodontics and surgery. And after that you need a specialization for doing it, and you need special training in basal implantology and also in the according with that in the prosthodontic procedures. That's the same, and also you need a good dental technician to do this work, which is completing the case. And so you have a good base for learning and for exerting also basal implantology. It's not done if you're fresh from the university and work immediate. You need experience. That's like in all medical disciplines. And then you may be a very, very good and successful doctor then. There are contraindications like for every medical procedure. There are the normal contraindications which are in every part of surgery that are of some lethal illness the patient may have, like cancer, and that must be treated before or healed before, and then you can do it. But there are special contraindications. Most of them are concerning the prosthodontic situation. If there is heavy bruxism, we had in our study bad results. And these were the main problem patients. And so it's better to exclude them before. Sometimes you don't know if they were removable prosthesis before. It's difficult to make a diagnosis of the bruxism. But, and then it's also a problem if there is bad occlusion. Bad occlusion may be corrected. And that's no absolutely contraindication, but you have to prepare the case before that there is a good occlusion plane. And also contraindication is psychological alteration, hysterical patients or patients with psychosis or depressions. They are not good patients for complex dental treatment. So it's also better maybe excluded or healed before by a specialist. In basal implantology there are a lot of contraindications. There is not possible or not sure to do it in fresh extraction sites. There is no possibility to do it in heavy smokers, and especially if you need bone transplantations or sinus lift procedures, there absolute no smoking is possible. You cannot use implants in cases of type 2 diabetes, and these are a lot of contraindications which are from the medical side. There are a lot of dental contraindications, like a small amount of bone, like severe atrophy, and so these indications, these contraindications are indications for basal implantology. There is no difference of the success rate in smokers or non-smokers in basal implantology. That's a most important thing, I think, because a lot of the patients are smokers and they may be treated as well as non-smokers. There's no detectable difference. Also, diabetes patients are good patients. We have no difference in the success.
This is a typical case where basal implantology is indicated, and this for some different reasons. The one reason is that the anatomical structures are very weak. There is not much bone under the sinus. All this here is air, and you can't implant in the air. You need some bone, and you have only this as structure. This is something like 1 millimeter of bone under the sinus. You can't utilize another system without further procedures like bone graft. bone grafting to insert implants here, but a basal implant can be inserted here without any difficulties. On the other side you have here teeth which are infected, and for some reasons the patient don't want to undergo different operations, so he would like that we extract all these teeth and insert the implants in the same moment. If you have infections in the mouth, as here, it is not permitted to install immediately crestal implants. With basal implants, because of the special mode of healing, there is no problem. We can take these implants, these teeth out. We can insert the implants, and we will make an immediate loading in the next 24 hours to 12 days. This is the clinical state of this patients. All these teeth show periodontitis, which we saw on the radio is very advanced, and not one of these teeth is fixed in the mouth, and this tooth you saw that there was a big cyst in the bone. After implantation of 6 implants in the upper jaw and 5 implants in the lower jaw, we fixed immediately, some hours later, these prostheses, a bridge which is stabilized by a metal infrastructure, and which the patient will have in his mouth for around about 40 days, up to 1 year, and then can be done the new structure, the new prosthodontics, or in metal ceramic, or in a ceramic structure.
Difficult situation in the mouth. Shall we help this patient with the basal implants?
Oh, this should be possible. Even in one only session, we can take out all these teeth. We can make the extractions. We will clean the bone and insert basal implants. This is a radiological aspect of this same case. You extracted all these teeth, and now you have to insert in this region, basal implants. Eventually, if there is enough bone, we could or use basal implants here or crestal implants. You have to decide this in the clinical operation. In the upper jaw, there is almost none of bone, almost no bone, only 2 or 3 millimeters here, and the rest is then the sinus where you can't implant. So there is only the possibility or to work with crestal implants and bone grafts to create bone for implantation, or we use a basal implant system, and we have with these 5 millimeters of bone here enough to fix them and to have a very good results in the following 40 years.
So here we see another very bad case. We see extreme decay of these teeth. These are only rests of teeth. And we also see a bad situation with the occlusion. It's a combination syndrome, you call it, with the scientific term. These are very long lower teeth in a high position and very low distal teeth, and no molars, no premolars. And we will see inside. We look to the radiography. Here in the X-ray you can see the same situation. This big difference in the high level and this low level in the molar area in the mandibular. You see the rest teeth in the maxilla, the broken teeth, and this patient wasn't able to not only to smile, he wasn't able to eat and to go out and show these teeth, and he has social problems. And we will see the result, what's done inside. The next X-ray, please. So you see here a lot of different implants. The tubo-pterygoid screws here, there are bicortical screws in the anterior region. They are inserted in the floor of the nose and of the maxillary sinus. And you see BOI implants. Always that's a combination. We are surrounding the maxillary sinus and we don't work inside the sinus. We stay just before, below and distal of this sinus. In the lower jaw it's most the same procedure. We have bicortical screws in the anterior area and distal over and above the mandibular nerve channel. We see these BOI implants with the platform, and this is a very stable situation. We can do immediate prosthetic dentistry, and you see here the temporary restoration. Immediate after operation, the patient will have a temporary restoration, build of resin. He can go out, he can look to get social rehabilitation, and he can eat. And so we see the final result. Some weeks later, you don't see any more swellings or bad things. You see normal teeth. Here the lips are spread it out, so you see the different situation between the natural gingiva and the artificial gum made out of ceramic. But with this material we have normal length of the teeth, we have normal proportions of the teeth, and are not overlong, no horse teeth, and it looks natural. And that's an image for the dentist, not for the patient, but that's how he looks like. And so he's going in the life, and that's it. Now we did this case, we did 6 years before. That's a long-term result we see now. The patient is not here actually, but you see no difference. There are no spaces between the teeth. It looks like at the first day where it was inserted. And we see often these long-term results. They are very, very stable. There are little changes only, and there's no discoloration, there's no stain on the teeth. That's a good ceramic material you need, and so you have these excellent results even after years. So Mrs. Harvard, you see here this is your case. These are your teeth before the operation. That one you had for some years. You remember? It was bad situation. You had here a big diastema. We had a discolored teeth in this area. We have also loose teeth here. And let us look on the radiography. What's inside? We have a look inside the jaw. There is here you see this teeth and this teeth here. They are badly decayed. There are big infections in the bone. It isn't regular bone, it's infected bone, it's absorption of the bone. And you have a big diastema here and also here. And there were possibilities to do it. We cleared this case very consequent and also in a good time. And then we look what's the result on the X-ray. The X-ray. Sorry. Yes. So you see here these teeth are removed and replaced by BOI implants. These are triple disc implants, And this one is a bicortical screw in the area of the canine tooth, and so we have very stable fundaments for your teeth. And these are built in a static position, and it's with a very high primary stability. And we will see what is 3 weeks later. We see the ready result. And that's now. That's how you look like. You see the diastema? No, it's disappeared. You see discoloration? No. You see artificial gingiva? Don't see.
Dr. Spahn, we have the patient with inflammatory process in the mouth. Shall we help this patient with big implants, with basal implants, or we can help him in this case with crestal implants too from big?
Yes, we have a case here of partially very atrophied bone. You see here is only some 1 millimeter thick bone structures under the sinus. The sinus, this is this empty space here, and here is the mouth where you can't implant, and you have only 3 to 5 millimeters, and here only 1 millimeter of bone. Also in the mandibula on this side you have the nerve which is going through the bone there, the dental nerve, and above the nerve you have about 8 or 7 millimeters of bone. This could be enough eventually for a crestal implant, but it will be very risky to do it. With that you go to the limits of this crestal implant system, and on the other side for the basal system it's a totally satisfying volume of bone. Now you asked if crestal implants are possible. I think that in this region we should use, if the bone volume is large enough, we should use crestal implants, and on the sides of the mandibula and on the sides of the maxilla we should use the basal implant system. Here you see that there are much differences in the bone conditions. Here you have around about 1 centimeter of bone under the sinus. You can use it, but 1 centimeter is not enough to insert in this region a crestal implant. So here also we have to take a basal implant system. Here we see the situation after you extracted the teeth. We see the empty alveolus, and we see now that here is almost 1 centimeter of bone highness, and here the very little bone structures, and here also we have around about 1 centimeter of bone, and here we have less than 1 centimeter of bone. So I suppose you agree when I say we should use basal implants in the sides of the maxillaries, and in the front we could use crestal implant system. So you did a very good case, Alex. This implant is very nicely inserted in this bone volume. Here also you see this is a basal implant which has a large base, and here is the abutment. Here is one crestal implant. Now this is also a basal implant. Here is a crestal implant, and here also a crestal implant, and in the upper jaw you have here and there the 2 basal implants, and the rest is solutioned with crestal implant because there is a lot of bone available.
Dr. Span, why in this case it's better to use PEEK implants?
So the PEEK implant system is a system where are available basal implants and crestal implants. The PEEK has many advantages in comparison with the Titan. The first thing is you can better control the bone because the opacity is not so important as in titanium. In titanium you can't really make a diagnosis of the bone around the implant, and here you look in fact through the implant and you can see all walls of the insertion channel, and you can control what happened in this insertion channel. The other advantage is you can shape the implant to have the abutments in the good direction, to have parallelity between all these abutments. And the third advantage, and why also we used this system here, is because this is a Bruxoman patient, and the PEEK as a polymer can compensate too much stresses by his intrinsic physical properties, and so even in Bruxoman patients you will not have too much constraints on the bone, and you will avoid osteolysis in the long term.
Dr. Span, why on X-ray these implants are like so?
No, they are made for that. We could have opaque implants which make the same effect as metal implants, that you can't control the bone around. But it is the great advantage of this system that you can regard through the implant and control all walls of the bone around the implant. That's a great advantage.
Dr. Span, I have the patient after 33 consultations in other clinics. She comes to me in our clinic and she wants to make a basal implantology, but afterwards she had titanium implants in her mouth. How we can help her now with the PEEK implants?
Yes, can you show me the radiography with the state like it is now, with these crestal implants?
Afterwards she returned to our clinic with this situation, and now
she lost this implant?
She lost the implants in position of 1H, 1,3 and 1,4. She hasn't bone in this position. How we can help her with the PEEK implants?
Now show the next one without this implant. There's one without this implant. Now, in fact, she has not much bone, but your first consult to recommend her basal implantology was a good consult. It's a pity that she didn't follow it, because in the meantime she lost this implant in region 1.7. Naturally, you can always help there in inserting here one basal implant, and eventually here in this region, in the region 1.3, 1.4, eventually to insert another a basal implant or a crestal implant, and I propose in peak to have the good answer to the occlusal forces, because this patient is also a Bruxoman patient. All these teeth have mobility, a big mobility, and there is really need to extract all the teeth. You see that the radiography confirms that everywhere there are inflammations, not only like marginal periodontitis, but also an apical periodontitis. All these teeth are moving, and we have to extract all. And now we shall see the result. In the same operation session, we could help this patient in installing implants in the 4 parts of the jaws. We installed basal implants everywhere where the extraction wounds were or have been, and some crestal implants where have been bone structures which were healthy.
So, Mr. Steiner, we try to solve your problems with the teeth, and we see here in this image that you are concerned with a lot of problems. And this one here is a removable prosthodontic, and you see other bad things here, this decay, and here long teeth, and you see a very inflamed gum. So your gingiva is very ill. You have a severe kind of periodontitis. You see here a suppuration, this typical white suppuration. It's specific for this aggressive periodontitis. So that means that even if we pull out all of your teeth, you need an antibiotic treatment to heal this periodontics. It's on the first view it seems crazy to heal periodontics without teeth, but aggressive periodontitis is an illness of the whole patient, of the whole body. So you have a big risk to develop an heart disease or stroke. And to prevent you from this, we will heal this periodontitis also, and despite all your teeth will be removed after that. So we look on the next image, we look on the radiography, what's inside. We look inside your jaw and inside your bone, and we will see. Okay, now if you have a look, you see a lot of prosthodontics, and you see a bad decay of your teeth, and also the bone jaw is resorbed around these teeth who have this aggressive periodontitis, and it's resorbed, and so that you feel the result, you feel loose teeth, and this is the reason for the disease you have. So after that we see what we have done. What's the result of the implantation? So we took a lot of teeth out. Some of them could be preserved. You have 3 teeth in each jaw remained. These teeth are sure, they are treated periodontically. They will have a very good prognosis for years, for decades. And the rest is completed by implants. You see here a tuber-pterygoid screw implant, and you see typical BOI implants which use a very flat and severe atrophied bone in combination with these bicortical screws, who use these screws which use the cortical bone here in the floor of the nose and of the maxillary sinus, and that's it why it's a very stable implantation. So it's the reason you can have the prosthodontic treatment and temporary immediate. After this surgery today you have these teeth. You can go out, you can eat, you can smile, and you are acceptable for other persons, and that's a good opinion. Also, you see there's low swelling, and had you pain?
No.
No pain. Well, a little bit. You need some medicament?
Yeah,
yes.
please. So.
That was okay, yes. That's normal. But 3 days after implantation there is no considerable swelling or bad appearance of your face. Yes.
Okay.
So you look very nice, like Elvis.
Now I can smile like Elvis.
That's it, yeah. That's from inside view, and you see here it's a special treatment for long teeth, to avoid to have long teeth. For example, as a horse, you look normal, because this one and this one, that's ceramic gingiva. You don't see any contrast between the original and the ceramic gingiva. It looks natural.